Right, thank you for the introduction there, Julie. So my name's Clare Rushton, and as Julie said, I'm a PhD candidate, potentially not for an awful lot longer, which is quite exciting as well. So in probably the final month or so of my PhD, and this is the first time I'm actually going to be presenting the entirety of my PhD thesis work, which is quite exciting as well. So, along with being a PhD candidate, I'm also a clinical psychology registrar and I work at a not for profit up in Newcastle. So, the title of my presentation today is Understanding the Support Needs of Families Affected by a Loved One's Alcohol or Other Drug Use. So, I'd also like to acknowledge the traditional custodians of the lands who we're meeting on today, and also the unceded lands around Australia. Where the participants who I'll be speaking about in these studies lived and completed this work as well. I'd also like to acknowledge everyone that's contributed to the entirety of this work. So my research team and supervisors, and also the lived experience experts who are represented in the work that I'm going to be talking about today too. I'd also like to note that this work was supported by an Australian government research scholarship and by the MOCRE. So to start off with, and I think a lot of this background is going to be very familiar to everybody here. There are estimates of around 100 million people or more than who are affected by a loved one's AOD use of somebody close to them. And this group that we're talking about is often described as a hidden population. And so it's actually really hard to gauge the true prevalence because families are not formally recorded and often don't identify themselves as needing support for a number of reasons that I'll go into as well. So there are some studies that are giving us a sense of the scale of this group that we're talking about today. And there was a recent study that came out in Germany a few years ago that was a fairly kind of nice prevalence study. And that showed that around 1 in 10 people identified as being affected by someone else's drug use as well. So as we know, the impact on families can be profound. Families are at greater risk of mental and physical health challenges, of relationship breakdowns. They also experience a huge amount of stigma and they're often blamed for their person's drug use, which can in turn compound that stress and act as a real barrier to seeking any sort of help for themselves as well. Despite these known harms, and we have known about these harms for quite a long time now, there is limited support still and limited accessibility of support, which is starting to change, which is really promising and really cool hearing April that there's 9 groups going. But yeah, this is still an area that we need to look at, and that's pretty much what my presentation is going to be on today, is getting to know the help and support needs of families a little bit more. So when I'm talking about affected families, the group that I'm talking about is really anybody who identifies as being concerned about or impacted by a loved one's drug or alcohol use. So this could be parents, partners, adult children, siblings, other relatives or friends. So historically, when we think about how families have been understood, there's been a lot of this idea of families being part of the problem or being kind of blamed or pathologized in their role within their family and their loved one's drug use. And this kind of comes often at the expense of providing families the support that they've actually needed as a group in their own right. And just kind of wanting to set the tone of the way I'm going to be talking about families in this presentation, it's coming from this idea which is really talked about strongly in the stress strain coping support model here, which is that we're centering families as a distinct group that have needs in their own right. So looking at this thesis as well, I've kind of been trying to address a couple of aims that I've just written out here, and this is going to be the focus of what I'm going to be talking about. And again, keeping in mind that this is with that underlying aim of centering families as a population with their own distinct needs. So firstly, we wanted to understand the characteristics of families and look at their indicators of wellbeing in an Australian context. Secondly, we wanted to explore how different types of relationships, for example, being a partner or a parent or a friend, shape families' experiences and needs. Thirdly, we wanted to really look at the feasibility, effectiveness, and the uptake of interventions that are designed for families themselves. And lastly, we wanted to have a bit more of a look at families' own strengths and see how we can better support their building of resilience rather than just focusing on what's actually been going wrong for them. So here's the first study in this body of work, and it's titled Characteristics of Family Members Affected by Another's Alcohol and Other Drug Use in Australia and Correlates of Help Seeking. So this study is currently under review in a peer-reviewed journal. So study one really aimed to build this clear picture of who is being affected by loved ones' drug or alcohol use in Australia. This study kind of had a few different aims, and the first one was to really give this zoomed out, broader idea of what this group looked like in terms of their socio-demographic characteristics and their psychological well-being. We then wanted to look at whether any of these things really differed as far as their experience based on the relationship that they had with their person. And the second or third part of the study was looking at help seeking a little bit more specifically. So looking at what families were doing to seek help. And we wanted to also look at correlates of accessing some really specialised family drug and alcohol support. And I'll talk to that a little bit more. So this study looked at the results of a cross-sectional online survey, which was called the Family and Friends Survey. So Australian family members were recruited via social media and through existing family support organisations, and recruitment took place between September 2023 and August 2024. So to be included in the study, participants had to be English-speaking Australian residents, and they had to be over the age of 18 and had to identify as being either currently or previously affected by someone else's drug or alcohol use. So an ad like this popped up on people's social media. Participants then would click a link which would send them to a landing page where they could hear about the study details, and then they could proceed to complete the survey on Qualtrics, which took around 15 to 20 minutes to do. So a little bit more about the survey itself. The survey was developed in consultation with some people with lived experience who were really helpful in getting the language right in the way that we were asking these questions. It used a number of questions to ask about participant demographics. So this is relating to the affected family member, and also we asked them about their person regarding, for example, their loved one's gender, their primary drug of concern. Then we asked a few questions around their psychological well-being, and we used some validated measures such as the caregiver burden scale. We had a scale assessing suicidality. We used the K5 to measure psychological distress, and we had some questions around their personal drug and alcohol use as well. And lastly, we wanted to know about their help-seeking behaviour. And so this looked at any support they'd accessed and the time it had taken to access that sort of help. So we had around 2,000 people who commenced the survey, and then we implemented a number of different data integrity measures just to improve the quality of response. And so these are those questions you might see pop up of select all the time if you're paying attention. And we pretty much removed everybody that didn't meet those requirements and had a few different measures to reduce bots and things like that, which is a bit of a problem in online surveys these days. But the nice thing about putting all these measures in was that we ended up with a really nice clean data set as well. So we had 1,756 participants that were eligible for analysis. And of those, we saw the majority is identified as being the partner of somebody who used drugs or alcohol. The next biggest group were parents at 28%. Then we had 13% identified as being adult children. 10% were siblings, 8% were friends, and 6% were other family members. So looking a little bit at the participant characteristics, we can see the vast majority were female at 91%. Median age of participants was 54 years. And 84% were born in Australia, and around half resided in major cities. So we saw 69% were currently employed and 54% had completed a university education. So a fairly educated group when we look at that compared to the average, the national average as well. In terms of their current living situation with their loved one that was using drugs or alcohol, 45% reported currently living with their person, 14% reported that they were no longer in contact with their loved one, and 3.6% reported that their person was actually deceased. So then we asked them about their loved one and what sort of drugs or alcohol they were concerned about. So 71% of participants identified alcohol as the primary drug of concern. That was followed by methamphetamines with 13%. And then 8% reported cannabis and another 8% reported other drugs. And you can see that listed along the bottom there. So 71% of our participants reported that they were concerned about a male's drug or alcohol use. 36% reported that their loved one had been involved in some kind of drug and alcohol treatment in the past. And 18% said they were aware that their person had injected drugs at some point. So this was a particularly concerning but unsurprising statistic as well, was that the average amount of time that people reported being concerned about their loved one's drug use was close on 10 years. So then we looked at those measures of psychological well-being, and we saw that pretty much, just over half of participants reported caregiver burden in the high range. Around the recent suicidal ideation, we saw that 23% of all of our participants reported recent suicidal ideation, and that was in the last few weeks. And we saw this was quite an interesting finding, that this was particularly high among adult children, and that was at 32%, which again, really concerning results there. So this one here is looking at psychological distress as measured by the K5. And this is looking at the proportions of each different relationship type that reported psychological distress in the high or the very high range. So you can see they're kind of similar to that result over with the suicidal ideation. We can see that adult children were particularly, a large portion, so 62%, were reporting that high or very high psychological distress. And as we kind of move down, parents were second, then we can see partners, siblings, other family, and kind of as expected, we can see that this sort of fits that pattern of people that you would expect to have those closest relationships, moving out towards people with the more distant relationships being less affected at that psychological distress level. Then we asked about family members' own substance use. So 15% reported alcohol use at risky levels, and we had 20% reporting recent illicit drug use. So that was in the last 12 months. And when we look at the breakdown of the types of illicit drugs families were reporting using, we saw 11% noted cannabis use, 8% were reporting using non-medical use of pain relievers, and 5% reported non-medical tranquilizer use. And these two last ones are particularly high, again, compared to the general population rates, which is an interesting finding. So now these questions are looking at help seeking. So this first figure here is looking at any help seeking whatsoever. So this was things like informal support, which might be a GP or specialised services, or it could even be just talking to families, friends and neighbours. So we saw that around 30% reported that they had actually sought some kind of help within the first year. Then we can see that 61% reported that they delayed help seeking beyond that year. And we've got this other group at the top there, which was 9% of participants who reported no help seeking whatsoever. And the average time that people were saying it took them to seek any kind of help was 6 years. So again, again, not particularly surprising, but really concerning result there too. So if we look a little bit more closely at this non-help seeking group, this here is splitting it up by relationship again, in the same way that we were just looking at with the psychological distress. We can see that friends, so again, the groups that aren't help seeking, we'd kind of expect that friends would be seeking help the least, because again, if we thought back to that other figure, they were the least affected when it came to that distress level. So that first one kind of makes sense. And it gets a little bit interesting when we then look at partners. So they were the next least likely to seek help, but we know that they were really affected if we thought back to those other slides. So again, we're seeing a bit of a delay or a mismatch between partners help seeking in particular. And then if we move down, I think interestingly here, we've got siblings and parents, and they, again, double negative here, but the least likely to not seek help. So they were more likely to seek help at some point. Okay. So here is a breakdown of all the types of support that were accessed at any point in the participants' kind of journey. So we've broken it down into 3 different categories here, and we can see that the most kind of commonly, frequently accessed support was this generalized formal support. And 69% of participants reported accessing some kind of generalized support and mentioning their concerns about their loved one to this professional. We can then see the next most likely support to be accessed was this informal type of support. And we can see that, yeah, 61% reported they'd mentioned this to family and friends at some point. And then if we look down here at the specialized family AOD support, so this is things like Al-Anon, like Smart Recovery, family drug support helplines, things like Addis. These are things that people might have accessed that would have kind of brought them to that more specialized support. And we saw that that was only accessed by around 34% of our participants. So we wanted to find out a little bit more about this group and really get to know who was seeking this sort of help and who maybe was falling through the gaps or this wasn't actually hitting. So we ran a logistic regression and we put in a bunch of different variables that you can see on this side of the figure here, just to see if we could look at correlates or relationships here and who was accessing this sort of support. So with this figure here, any of these lines and dots that are fully on this side means that they were more likely to access support. If they're on this side, it means they were less likely to. So move across to this one. You can see where we started to see a bit of a pattern emerging around who was accessing this specialised support. And what we found was that families who sought specialised support were more likely to be older. They were also more likely, more often reporting that their loved one had previously engaged in some kind of drug and alcohol treatment in the past, which I think is a really interesting one to look at, that maybe that's a bit of a pathway where these people are getting the information about these supports, or they might just be innately help seeking as a group. On the other hand, help seekers were less likely to live in the same household as their loved one, which is quite interesting as well. So living elsewhere was actually predictive of seeking that help. And they were less likely to drink alcohol at risky levels. And again, another interesting finding there too. So a bit of a summary. The findings of study one really showed some quite concerning findings around these really elevated levels of psychological distress and suicidality. And these rates were a lot higher than we're seeing in the general population. Keeping in mind, this is a self-selected sample, this isn't a prevalent study, and there are lots of factors that would be leading to this group in particular putting their hands up to participate in the survey. But again, I think the size of the sample and the level of this distress is definitely worth paying attention to. And I think despite this really kind of high mental health concerns, families were really often delaying help seeking, or when they did, they were commonly seeking informal support through those families and friends, or generally non-specialised sources of support. And so while these non-specialised supports are really important, we really need to equip these more general practitioners in how to support families and get their needs met. Otherwise, families might be walking away with not the best experience of help seeking, which we know can delay future and put off future help seeking efforts as well. And so what we really need to do is get to know these specialised interventions a little bit more and just find out who's, again, a bit more about who's accessing them and how effective they actually are, if this is something we should be putting our energy into. So that brings me to study two. This study is called The Effectiveness of Psychosocial Interventions for Families Impacted by Another Person's Substance Use, a systematic review and meta-analysis. So this study was also, this one was published in Drug and Alcohol Review, and you can have a look at that paper there if you like. So the aims of this study were really to synthesize the literature looking at the effectiveness of these interventions for improving the well-being of family members. We wanted to look at this on measures of things like depression, anxiety, distress, quality of life, general family functioning and coping. So seeing if these interventions could help families in any of these areas. So we also wanted to have a little look at whether there was a difference in these interventions, whether they were delivered in groups or in a one-on-one setting. So a systematic review, for anyone that's not familiar, is pretty much just a really big search through all these different databases to look at all the studies that answer a certain question. And so what we do, we throw a really big net out by using these specific search terms. And then we slowly kind of whittle it down. And you can see this on the right there, this figure. This is kind of showing that process. So we started with over 6,000 papers. And we go through them all and we eventually finalize all the studies that actually do answer our question. So in this case was looking at the effectiveness of interventions for families. And in our case, we got down to 19 studies that we can include in our paper. Okay, so this is a bit of an overview now of the study characteristics of those 19 studies that we were able to include in our review. So you can see here that 11 of the studies were randomized control trials and 8 were pre-post studies. The majority of these studies were actually conducted in the USA, followed by Iran, and then a number of countries just had sort of one study each. Again, probably unsurprisingly, the majority of participants were female. So we saw 73% of all participants across all of these studies were female. So then looking at the types of interventions that these studies were actually assessing, we saw that I think around 11 of these studies were looking at individual interventions. So when I say individual, that's delivering an intervention in that one-on-one setting. And then we saw 6 of these studies were looking at a group intervention, and one of them was actually comparing an individual to a group. Only 3 of the studies were assessing interventions delivered online, and all these ones delivered online were actually self-directed, so the participant just sort of clicking through in their own time. The types of interventions we saw, primarily craft was being evaluated, followed by 12-step based programs and the 5-step method. So here's a bit of an overview of the measures that these researchers were using to look at whether these interventions were helpful for families. You can see that depression, distress, coping, family functioning, and anxiety were used pretty frequently. Less frequently used were quality of life, physical health, and their own substance use, which again is fairly interesting, particularly given what we know and the impact that can be happening to families. So as far as these outcomes, what we did, we pulled a lot of these results and came up with a bit of an overview of how effective these interventions were. So we saw that of the individually delivered treatments on the left here, we saw that the interventions improved participants' depression, they improved distress, family functioning, and coping. And of those group-delivered interventions, we saw also improvements in depression, distress, and coping. So fairly promising findings across the board there. There were some common elements that we saw across all of these different interventions. The main ones I've just listed here were education and information of some kind that was being given to families. Giving support and around coping skills was another really common element. Ways of supporting behaviour changes, such as setting boundaries and working on effective communication, was also fairly common. There was also commonly an element of self-care and focusing on what families' needs were. And obviously in those group programs, there was a real element of that mutual support, which was quite important as well. So there were also several limitations of the literature. So a lot of these studies, when another part of the systematic review process is looking through all the different studies and giving them a rating of how much bias they could have been introduced during the process of that study being conducted. And so we saw that 9 of the studies were rated as being high risk of bias and 10 were moderate. As far as the actual samples that we were seeing, the participant samples that we're seeing involved in these studies, we saw a lot of these studies had quite small sample sizes and there was a fairly high dropout rate. So a lot of people who started the intervention, there might have been a large group that started and by the end there was only a small portion left that was still involved. There was also, again, that 73% female participation, so limited representation of other groups and demographics. Looking at the intervention limitations more specifically, most of the interventions were for families affected by loved ones' alcohol use, and there weren't any interventions that were actually delivered via telehealth. So other than these self-directed sort of click-through programs that were done online, there wasn't any telehealth or video conferencing interventions. Regarding the outcome measures, we saw, even though a number of studies were assessing things like depression and anxiety, what we saw was they were using really different ways of assessing those things. So it was quite inconsistent, which made it hard to sort of compare whether these groups were effective or not. We also saw limited follow-up assessment, so it was mainly like a pre and a post around the intervention. No real assessment, say 6 or 12 months later, so it's hard to know whether those changes were sustained. And we also saw a limited assessment, I think, as I mentioned, of that physical health and substance use among families as well. So next steps, the review really showed promising outcomes for these interventions, but the findings were really limited by these low quality studies with small sample sizes and these unstandardized measures. I think another limitation there was the focus on alcohol, and not many of these studies were addressing families who were affected by other drug types. For example, methamphetamine use, which as we know is really common, particularly in Australia. So I think that note as well about online interventions not being used so much is really important too. And as we know, we need more accessible support for this group, which leads me to my next study, which study 3. So this is looking at the feasibility of an intervention for family and friends affected by another's methamphetamine use. So this study was funded by NCRED, and it was conducted in partnership with Smart Recovery. And this one's also published in the Journal of Substance Use and Addiction. So the aims of this mixed methods study were to investigate the feasibility and preliminary outcomes of a group program designed or delivered to a cohort of families affected by a loved one's methamphetamine use. And this study also wanted to examine the benefits and the limitations of delivering this group remotely. So this was all done via Zoom. So I got to be part of NCRED have an awesome program called the Video Abstract Project. And this was I was involved in developing this. It's fairly brief, it's about a 3-minute animation. And what these animations are designed to do is just to really summarize research studies and present them in a really accessible way. So big thank you to the team at NCRED and at Insight for putting this together. So I'm just going to play this video for you now.
Methamphetamine use not only affects the individual using the drug, but it can also impact the well-being of their family, including their loved ones, relatives, and friends. Affected families face many challenges, including financial stress, involvement with the criminal justice system, and fear for the safety of their loved one and the entire family unit. This in turn can have consequences for their own mental and physical health, their relationships, and overall well-being. Unfortunately, despite the recognised impact that a loved one's substance use can have on the family, there is a scarcity of evidence-based treatments to support families as a population in their own right. Smart Family and Friends is a structured 8-module mutual support group developed in 2009 by Smart Recovery. The group has been adapted to align with the stress-strain coping support model and has been delivered both in person and online. However, prior to the current study, no formal evaluations of the program have been conducted. The aim of our pilot study was to assess the feasibility of delivering the program via video conferencing and to gather preliminary data on whether or not this might be helpful. To assess feasibility, we looked at attendance rates, participant satisfaction, and fidelity ratings, how well the program was delivered, and conducted semi-structured interviews with participants to understand what it was like for them to be part of the group. Preliminary outcomes were assessed using measures of distress, quality of life, and family functioning that were administered before people attended a group and again after the program had been delivered. We recruited 45 affected family members between March and October 2021, who were Australian residents aged 18 years or older. 88% of participants identified as female, 64% were aged over 50, and 69% were the parent of an adult child who used methamphetamine. The average duration of their loved one's drug use was 11.6 years. The interview data showed people found the mutual support component helped to reduce feelings of isolation, and that they enjoyed the accessibility and convenience of the video conference delivery. Participants also spoke about challenges of the online format, noting that there was less chance to form impromptu connections with other group members. These results provide initial support for the Smart Family and Friends program and add to the literature demonstrating the feasibility and benefits of providing treatment to families independent of the person using drugs. These encouraging findings also show that a mutual support group delivered via video conferencing may be successful in improving mental health outcomes for affected families. These results are an important step towards getting families the help they need and merit further randomised controlled trials to assess the effectiveness of these treatments.
Okay. So overall, the feasibility study really showed us that this specialized group intervention for families was feasible. And it showed, again, it wasn't a randomized controlled trial, but it did show some really promising outcomes as far as improvements to families' overall well-being once they were participating. So I think the qualitative findings of this study also really highlight the value of listening to families' lived experience, just to actually understand what families are looking for when they go to seek help. I think that's going to be so important to really, really prioritize when we're looking at how we can support families and tailoring it to actually meet their needs. So finally, to study 4, this study is called A Qualitative Exploration of Affected Family Members' Responses to Methamphetamine Use Using the Family Resilience Framework. So this study was actually published earlier this year in the JSAT journal as well. So the aims of this qualitative study were to explore how families themselves make sense of and respond to their loved ones' methamphetamine use. And the real sort of goal around this was positioning families through a strengths-based lens. And we did that, I'll explain that a little bit further, but using that resilience framework. So this study actually used the baseline interview data from study 3, that feasibility trial. And so kind of keeping in mind that all the families I'm talking about today that are represented in these interviews had actually reached out for some kind of help. So keep that context in mind when we're interpreting these results as well. So these semi-structured phone interviews were conducted in 2021, and data from 24 participants was used in the qualitative analysis. So the analysis was done through thematic analysis, and we used these iterative categorization techniques as well to analyze the data. And the final theme development was actually conducted using the Family Resilience Framework. And that's the framework that you can see on the right there, which was developed by Walsh in 2016. So specifically, this framework gives a bit of an overview of these key features seen to facilitate healing within families that are facing adversity. And this model has been used to look at families with all kinds of stresses in their lives, like chronic disease, people experiencing really traumatic events and things like that. And so in particular, this study focused on this top portion of the model, which is called the belief systems. And this looked at meaning making, positive outlook, and hope, and transcendence and spirituality. So now to the results. So the first theme that I really wanted to speak to was called acceptance and resignation. And this was spoken about by pretty much all of the participants that we saw in the study. And they spoke about this in a way of navigating acceptance in this process of making sense of their experience, supporting their loved one. And in particular, families acknowledged the cyclic patterns of the addictive behaviours, which I think we particularly see in a drug like methamphetamine use as well. And the recognition of their own limitations in what they could actually do to influence their loved one, and this cyclic and often chaotic and terrifying kind of nature of this drug use. So at times, this acceptance, it wasn't always a sense of hope. It was often actually a sense of resignation and hopelessness as well that people were talking about. Although what we did see was families who spoke about and acknowledged the effect of this stress and strain on their well-being, they did seem to demonstrate this real empowerment to prioritise their well-being. And I think this is demonstrated in this quote here, but I think I've got time to read this one out too. So I just need to be able to cut myself off from the situation. and then try and get my, I guess, sense of well-being back. And I think I'm on the edge of it. I can't use my son as an excuse to not be good to myself because it's the worst thing I can do, really. So the second theme I want to talk about was called Alternative Perspectives to Develop a Compassionate View of Addiction. So this idea of taking different perspectives of addiction seemed to shape almost all of participants' perceptions of how they really understood themselves and their role in this situation they were in, and also the way that they understood their loved ones' behaviour. And people spoke about being exposed to these perspectives through support groups, through friends and professionals, and that it really helped them understand that it wasn't a matter of my loved one is bad or they're doing this to hurt me, but it kind of helped them understand where addiction might stem from or come from and help them sort of reframe their loved one's use in a different light, which again helped them to turn that view as well into a compassionate understanding of the way that the stresses that they were actually going through as well. And I think this is really highlighted in this comment by a mother who described this process of learning about a trauma-informed approach, and that this was actually really positive in as far as the impact it had on her well-being as well. So their take on it is that it's all trauma-based. It's not a choice. It's not a disease. People use drugs so they feel better because they're struggling. I believe that theory. I've done some other reading and lots of self-help stuff. So I think I've come to a more compassionate place with it, which makes it probably a bit easier to deal with. So the third theme that I want to talk about is called transcendence and finding purpose. And this really speaks to this idea of families zooming out and connecting with these higher values. And this was actually really important for families in making sense of their experience and where they were at. So participants spoke about taking a step away from their role supporting their person and coming back to reconnecting with their own identity. And many participants actually spoke about having lost that sense of self and that identity in supporting their loved one. And so at a practical level, this really just looked at people engaging with things that they used to enjoy and reclaiming a stable sort of sense of themselves and a sense of purpose as well. So some people spoke about the use of faith or trust in a higher power to instill that confidence that what they were going through was actually part of something bigger than themselves. And I think people also found that same sort of sense of going through something bigger through philanthropy and this goal of giving back and making their really challenging experience count for something bigger. I think that's really represented in this parent's quote. What helps me is like what I'm doing with you. I feel like I'm making a small contribution. I'm hopefully making things better down the track. So the last theme that I want to speak to was about holding on to hope and a positive outlook. And this really presented in two main ways. So this was either relating to themselves or relating to their loved one. So firstly, people spoke with encouragement about their own progress, and they were really reflecting on their capacity to adapt and develop these healthier coping strategies. It was really interesting. Even it kind of didn't matter too much where these loved ones or where these family members were along their journey. A lot of them could identify some kind of shift that they'd had and could appreciate that progress that they'd made. So hope and a positive outlook was also used. It was a bit of a tool to maintain this sort of trust that they had in their loved one's recovery journey. And it was sort of spoken about as a way to balance this huge weight of this grief and uncertainty. And holding on to this hope was a way of lifting them out of that huge weight that they were carrying. And I think, again, this is represented by this parent. But anyway, he tells me he went to AA last night. So I've just got to hope and pray that he's telling the truth. When he rang me and said about it, I tried to be positive and said, "Oh yes, did you really go? Well, that's wonderful." I don't say prove it or anything like that. You've got to trust, I suppose. So this qualitative study really shows that families are often actually drawing on really deeply held values and have a huge amount of emotional endurance with what they're going through. And they're leaning on these other kind of forms of support that are often informal, and they've often got to be quite creative in the ways that they access that support. So I think by learning from what families are already doing, we can really use that information to start to design and start to kind of adapt the interventions that we've already got to help families enhance those strengths and the things that they're already actually doing quite well. And I think these findings also really enforce the need for a really flexible and affirming services for family, and just to help them see that and recognise that they actually are deserving of support in their own right. So there are some really important limitations to keep in mind across this whole body of work that I've just presented. So the people, I think this keeps coming up as a common theme, but the people that were participating in my study were fairly middle class, generally older people and predominantly women. So we don't really hear a lot from men or from younger people or from people from different cultural backgrounds. So I think it's going to be quite important to look at in future studies as well. Another one that I've already mentioned was that self-selected convenience sample. And again, by people, if we're kind of thinking about the types of people that are going to put their hands up to participate in studies like this, they might look quite different to people that haven't, maybe are at the start of their loved one's journey and aren't even kind of self-identifying as being an affected family member at this stage. So thinking about ways that we can start to access people at all different stages across these journeys is going to be really important for future research too. As well, the type of cross-sectional research that I've presented today doesn't really let us determine causality. So we can look at associations, but we can't say that this thing causes this. And I think particularly the survey study, while it was a nice large sample, what we're really looking at is just a snapshot of one group. This isn't a population level prevalence study. So that is still some really important information that's actually missing from our understanding of families in Australia. So general conclusions and implications. Across the 4 studies, we saw that families were experiencing these really high rates of psychological distress and suicidality. Many who were seeking help, they were doing it after pretty substantial delays, and they were most likely to turn to these informal or non-specialised services. And this is despite, again, living with this person's substance use for many, many years. We showed, though, that interventions are not just feasible, that they actually seem to be really effective, but we also need to work on making them more accessible and more inclusive for different groups of families as well. And I think importantly, despite the huge amount and huge length of time that these people are dealing with this stress, they are showing that they're able to adapt and to cope. And all of that is in the context of very limited support, huge amounts of stigma, and not really getting any recognition for what they're going through as well. So in the future, I think it's going to be really important to think about how we can train general health professionals just so that they've got a little bit more awareness of how to best work with families, because we saw that families are going to these groups. And so if we can help like upskill professionals to recognise or just kind of build some questions into their assessment, and also maybe looking at developing some really brief interventions that can be used so that families, that we know that even if they're not seeking that specialised treatment, they're still getting an adequate level of care as well. It's going to be really important for policy and government strategies to acknowledge this huge mental health burden that I think we're all already aware of that families are experiencing, and really use families' lived experience and bring them in to be part of the conversation in designing these services. I think in the future as well, it's going to be really important to establish just get better data collection going, particularly at a population level. So we've got, for example, the National Drug and Alcohol, the survey that we have every couple of years. If we could put some questions around families in there and just start to get a bit of an idea around this picture that we really don't know a lot about at the moment, I think is going to be really important. So there are some references. Thank you. So if you want to scan that QR code too, I've made a little website just with my papers, and those videos are there as well if you're at all interested in the future. But feel free to reach out via email if you'd like to talk through anything.
Did everyone have time to get that QR code? I saw many people putting their phones.
So I can share again if you like.
Everyone had an opportunity to get that? Yeah. Everyone's nodding. Well done, Claire.
Thank you.
Well done. That's a fabulous presentation on your research. I'm wondering if anyone's got any questions to ask or comments. I can see Megan's clapping.
I've got one question. A comment. I thought the way that you presented the research was really, really clear. And yeah, made it really digestible. Obviously, I know of some of your work, but to see it all together like that was just brilliant. I was really interested in the 45% percent had spoken to their GP. And I know it was of a smaller subset. But yeah, that surprised me. We've been doing some work at the moment, not specifically around family and friends, but just trying to get GPs to be able to have destigmatizing conversations, to know about smart recovery. And yeah, it does seem like they're a bit of a safe place for people to chat to. And I just wonder if it's worth us thinking about expanding on that project to actually include family and friends, because I would say their awareness of formal support, whether it's Al-Anon or SMART or anything else, would be very, very low. So when they are going to their GP, what advice and support are they giving them? So that was a little bit of a light bulb for me, just to think about how do we actually support GPs, because if they're going to them and they're not getting the information they need, that's it's a big issue.
Yeah, it's a good point, April. Did you want to say something, Claire?
Yeah, I completely agree. And I think it's really, I think you're so right that GPs are often that safe space. And if we're going to think about the relationship people have with a GP, it might be like a family GP. They might know the other members of the family. There's those kind of difficulties around if I think something that comes up as far as hesitancy to support families is around that confidentiality as well, and what they can actually kind of do without, if they are seeing multiple family members as well. And I think that also speaks to the fact that a lot of GPs probably just aren't aware that there are supports for families totally independently of wherever their loved one is up to in their journey. And I think it's a super important piece of work.
I don't want to spend too much time of this meeting, but I'd love to chat to you. We got federal funding for this GP campaign, and so I'd love to use some of the research to potentially go back and say, and I don't know, Helen, it might be something we'd be able to do jointly and actually, let them know about SMART and Al-Anon and do something with GPs, because we've got a foot in the door now in that we're got access to them, we're giving them information, so to be able to bring family and friends into that would be great. So yeah,
I'd be interested in that as well, April, just because I think the other thing GPs are actually really good at is referring on mental health plans now.
Yes,
they're really good on that, and that could be another way. Yeah, Pauline, did you want to jump in there?
Yeah. Just speaking from New Zealand point of view, we have health practitioners in virtually every GP's practice now, and with the quarter of an hour, usually consultations with doctors, most doctors will refer to the health practitioners, and we've been training the health practitioners in working with impacted family members through a whole lot of ways, a whole lot of conferences and things like that. So that's because they can spend an hour with people rather than 15 minutes. So we found that's a really productive way to work.
That's actually a really good point too, Pauline. I don't think a lot of our GP practices would have a health practitioner per se, but they might practice nurse.
Yeah, some of those sort of things.
Yeah, and that's a really good point, because they do have more time with nurses are often tricky. Hopefully no one's a nurse here. Sometimes they're a bit tricky to work with. Oh, someone just disappeared. I wonder who that was.
Luca.
Yeah, I think it was Luca. He said he has to jump to another meeting.
Oh, did he? No. Oh, yes. Thank you. Yes, he's just said thanks for the presentation, Claire. Any other questions or comments?
I just wondered. I just wondered if there was any well-being instruments that you used when you were doing your, like the Warwick Edinburgh and things like that. Were there any actual instruments that you used?
With just across all the studies, or
Yes.
yeah, so we use
to test well-being.
to test wellbeing specifically. I don't think we do. We had a quality of life measure. The survey, I used a few more sort of wellbeing related measures, including like social connections and loneliness, and a few other kind of broader areas as well, which I haven't actually looked into yet, which would be really interesting to start to analyze that as well. I think that's a big part as well, looking at getting a really standardized. I know the Vellemans and Affinet have developed that family measure. Be really nice to get that validated and put out and being able to use consistently or something along those lines.
The one I was thinking more about was the Warwick Edinburgh. We use that for well-being. It's a very well researched assessment, and we use that especially with impacted family members where the focal person has actually died. So we can't use the family member questionnaire before and after in step 1 and step 5. So we use the Edinburgh, Warwick Edinburgh one. I think that if you have a look at that, that's really, really good.
Do you use that consistently through your 5-step?
Not through the
like
5
a pre-post, or
we have pre and post for the 5-step anyway. That's a 33 questions. But that's different from what I'm talking about. That's when the focal person has died or something else has happened, and we don't use it then. We use the Edinburgh Warwick wellbeing scale when it's really good and it's very well validated.
Yeah, great.
That's great. I have to have a look at it. How many questions is it?
There's only about 10 or 11. Not the 33 that for the impact for the 5-step, which are excellent because we get such good data. I thought your presentation was excellent, Claire. I'm sorry I was in another meeting just to start. I thought it was excellent, and it absolutely fits with everything that we found out. I was running a conference on the west coast of New Zealand yesterday, and it just reiterated all the things that you are saying that we are finding in our research, around building resilience, that the real importance of strength-based interventions, because it's not about the problem, it's actually about building on the strengths. And it's just really, really good research. I'm really impressed.
Yeah.
Thanks so much, Polly.
Very true. And Pauline and Claire, you might actually know this, but the FMQ was validated, I think.
Yeah.
It's a validated tool.
Yes, over 20 years. Yeah.
So just
I don't know if I've come across that paper.
Yeah, there's a
the FMQ is what we use in the 5-step at session 1 and session 5.
Yeah.
And all the data is sent to the UK, so it's and peer reviewed. So,
I might be able to I might have that paper, Claire.
Yeah, that'd be great.
Yeah. Does anyone else have another question, or?
I just wondered for Claire, sorry everybody, you talked about having shorter questions, a shorter intervention. We've actually found the single session consultation that we've trained our accredited practitioners in from La Trobe University. We've actually found that stunningly, spectacularly good, because actually most people who do that single session, especially around telehealth, because we've got 1,800 sessions around telehealth now, that they actually really appreciate the single session, and most of them go on to the 5 counselling sessions. And because 92% of them complete the 5 counselling sessions, it's really that single session is really great, because they get a taste of what they need and what they want.
That's such a powerful gateway to kind of open up. Yeah.
And I think I think that's from the Bouverie as well, isn't it, Pauline? The single session.
Yes, your Bouverie. Yes, it's from there. Yeah. That's what we train after people. Yeah.
And there's lots of evidence for that as well, outside of drug and alcohol, just working with families, because that's so you'll learn about that, Megan, because you're studying with them at the moment, aren't you? Yeah,
it's great.
Claire, can I ask you a few questions? The meta-analysis,
Yes.
was there a period of time for the articles? Was that one of your criteria, like the last decade or the last?
Yes, it was the last 10 years.
The last 10 years.
It was. Hang on, let me check.
Yeah.
Yeah. Yeah, which interestingly, I think in the last since that paper was published, I think there's been a real boom in a bunch more intervention studies. So it's already been outdated.
That's interesting as well, because it's the last 10. So so there were 6,000 articles in 10 years.
These were, so again, when you kind of throw the net that wide, heaps of those, there might be sort of keywords that get flagged at anywhere in the paper. And so often they'll be talking about quite irrelevant topics that just happen to have those keywords, hence the filtering process. But yeah, it takes a lot of clicking through, manual sorting. As Paige knows very well.
Yeah, they look easy, those meta-analysis, but they're not, are they?
They're very time consuming, I think. Yeah, because you have to be it's a very, very sort of strict structure and protocol, and you have to be very kind of diligent with it, which is why I guess they're great pieces of work when they're finished, but they do take a fair bit of time. Yeah.
Yeah. And the other thing I was curious about, and I might have misunderstood because it might have been from different studies, but you had, I think, initially said 9.5 years since the person reaches out, does any help seeking. And then in the next time it was 6 years. But was that a different study?
Yeah, so there was 3 kind of numbers that were chucked around. So one was the 6 years was the time to help seeking since first becoming concerned. The 9 years, 9.5 years was for the survey study. That was how long they'd been affected at all.
Right.
So whether they'd sought help or not, what was the total length of time that they'd been affected by? And then the one in the video, the 11 years, that was that same statistic of how long have you been worried, but that was for a different cohort because it was the people that were involved in that SMART intervention. So yeah, a few numbers telling a fairly similar story, but a little bit confusing. Yeah.
And then just because I'm interested in drug-related death as well, because remember in that first study, you were looking at the relationship, and then you told there was 3.6% where the person had died.
Yes.
And I might be making an assumption that it was a drug-related death.
So not necessarily.
Right.
No. So some people, and I didn't capture this that well. This is one of my survey design regrets. But looking in, there were a few sort of qualitative boxes that people could sort of type in if they had anything more they wanted to share. And some of the people who were talking about someone who had died was actually an adult, like a parent, that they'd grown up with their drug or alcohol use, and then they'd passed away, and this person might have been in their 60s or 70s reporting on their experience of having carried that throughout their lives. But some did explicitly say it was by suicide or by drug related. So, but it wasn't, it was just kind of hit and miss as to whether people added those comments, unfortunately. I could have had such a wealth of data for you to mine, Julie.
I know. And then I could have gone, and did you know if they were siblings or what the relationship was?
We could work out the relationship, like the if they have died and the relationship, and kind of put those together, but cause of death wouldn't pop up, unfortunately. Yeah.
And then and I think I've said this to you before, I'm not surprised at all about the general practitioners, whether it's GPs or generalist counsellors. And that's because, and I didn't report on this in my research, but one of the ways that I ended up trying to recruit was by going to generalist counsellors to refer people that they had seen.
Interesting.
Yes, I know, because I couldn't, because siblings don't come forward very often. Yeah. So
that's really, I feel like kind of thinking about April's comments as well around GPs. I think that's such an important piece of work for that, just helping GPs have a bit more training, a bit more knowledge around how to manage that first response, that just initial, because families are going to be, it's such a challenging thing to speak about. that
Well, yeah.
if
Yes.
that first response is stigmatizing or whatever that is, just by kind of default, then that could shut down a whole avenue of help seeking down the track as well. Yeah, I think it's a really important, such a gap, as April says in the comment. I definitely agree.
It is such a gap. That's exactly right. Yeah. Now, that's all I wanted to say. But it was an excellent presentation, really. Very, very interesting. And so relevant to all of us. And such a fantastic piece of work, Claire. Really. It's really going to be so helpful. I can see us all using it into the future.
One of the things you said, Claire, was about fidelity. You had 45 clients or impacted family members, and you talked about fidelity. Can you just talk a wee bit about how you measured the fidelity of the?
Yeah. So it was every group, once the group had been run, it was just like a basic checklist of each of the elements that needed to be covered and whether they were covered or not. And it was done through, for every couple of sessions, it was done by a third party that would sit in. And then in the other sessions, I think it was the co-facilitators would go through and do it. So yeah, just to kind of check that everyone was receiving all elements of the intervention.
And just so I'm including everyone, Mark, I'm not sure if you might have, whether you wanted to ask anyone anything. I'm not sure exactly when you came in during the presentation.
Too late to really come in. I'm just, but I will be going away to read up on what Claire presented. But yes, no, I apologise for being held up in another meeting and didn't get back to the office in time. So
yeah, no need to apologise.
Yeah.
We're recording it, and Paige then will put it on. Do you want to talk about that, Paige? What you then do with the recordings?
Yeah, so I'll post it on the Google Drive where we've got all the other recordings from previous presentations, and we keep usually put some minutes in there from things we discuss as well. Yes, definitely everyone should check that out. There's other resources and things there too.
Yeah. And yeah.
Yeah, maybe we can send around another link to that after today. I'm happy to send the slides around as well, if that's helpful for people too, if they're interested.
I have to say, Claire, your slides on quantitative research do make it very digestible, because often I look at people's quantitative work and I just glaze over with all the graphs. So, you know, how you do it is clever, really clever. I wish I had skills.
I'm glad to hear that. I think I worry I swing the other way sometimes, and I don't want to dumb it down too much and make everyone feel like they're not going to get it. But yeah, that's good feedback to get to.
And Ros and Helen, anything, because you know it's relevant to Al-Anon, of course, as well. I don't know if you wanted to, anything you wanted to say, Helen?
Fascinating research, and thank you so much, Claire. I know we encourage as many of our members as possible to take part in the research, and the results are not a real surprise to us in terms of the demographic, how long it takes people to get help, and the kind of effects that any of the self-paced or support group stuff, the effects that has in terms of decreasing mental health issues, increasing coping skills, that kind of stuff. None of that's a surprise to us. We'd love to have that amount of research done on Al-Anon, to have some quantitative stuff. Everything we have is fairly anecdotal apart from our own membership survey. But I really appreciate the opportunity to have even a small involvement in it. But great work. Thank you.
Yeah, and really appreciate. Yeah, no, so appreciate you guys putting it out to your members too, and thinking about your kind of internal member surveys. I think a lot of those, as you say, the results really match up.
Yeah. And I think Megan might have wanted to say something as well.
Well, just that it's, fantastic, and I'll definitely be sharing the slides around the office here. And thinking, have you produced a poster version of those PowerPoint slides or something? Because we were talking about our mutual aid group Compass, and whether just having that kind of statistic around how the sort of validating, destigmatizing of takes a long time to ask for help, that kind of stuff to give to our participants, to kind of give them a sense of they're not alone in having taken a long time to get here or in feeling isolated, that sort of thing. Do you have a 1-page or 2-pager?
It's a really, really good point. It's something that I've had a poster made up for I think for the SMART feasibility study and for the systematic review, but not yet for the survey data. And I'm hoping to make that up for the survey data, just to there was an option for participants to click whether they wanted to receive the results. And so I was going to send them the paper and also a more sort of pop art digestible version of it. So I'm definitely hoping to work on that over the next month or so. And I'll send it around as well once that's done.
Fantastic. Thanks, Claire.
All right. Anything else anyone else wants to say? Okay. So, what are our plans page for the next meeting and the date? And
I'll just check the date. But the plan is to have family drug support from Australia give a presentation. I do have to confirm I'm not sure if it'll be Chloe or Anna or someone else who will give the presentation, but I will be in touch with them, and once I've confirmed that, we can get that invite sent around. At the moment, tentatively, it's the 21st of August. But yeah, that might move around a little bit. But I think that's the last one we've got booked in for the year. So yeah, if anyone else wants to put their hand up.
What about Luca's research? What do you think? Could we approach Luca? Mark's got his hand up. Have you?
Not for that reason.
I wasn't sure I was going to direct you or not, but no. Did you have another comment?
No, I was really interested in what April was saying before about the engaging with GPs, and I kind of think, hey, it's an interesting research, and I just wanted to throw it out there if anyone has done research in the ways of getting information to families and loved ones to know about this, because I'm guessing, Claire, and apologies again for missing the presentation, but I think it was Smart Recovery that did put out that average 5 years before a loved one would seek help. Is that sort of part of the research that you were presenting, Claire? And if that was the case, I just wonder what mechanisms could we do that might lessen that time gap? And I just wondered if there was research out there that actually showed more creative ways of getting the message to loved ones. Yeah.
Oh, you go, April.
Oh, I was going to say there's varying research I'm aware of in terms of the time it takes to seek help, both for the individual and for a loved one. And I think a campaign or awareness around what support is available is so missing. I think it's such a challenge for people to even, I think what's kind of missing is awareness of services and then some kind of navigation tool to actually go, well, what's going to fit best for me? Like people are just left to kind of flounder around and find what might work. And yeah, I'm not aware of the right number. I know that on average it takes 15 to 18 years for an individual to seek help. But for a family and friend, I've seen various numbers floated around. So I'd have to fact check the one that Smart sent out that you're referring to, Mark. But, I think we all know it takes a really long time. And then, once they do want to reach out, how do I know what's right? Do I want individual counselling? Is group support for me? Is it a 5-step model? Is it a 12-step model? Like it's, people are just left to kind of try and figure that out. I do think GPs are part of the solution, but I think what I found interesting in your presentation, Claire, was that kind of compassionate view of addiction. And, you know, I think there's like a whole piece of work to be done around that for loved ones. And yeah, but I'll have to fact check that, Mark. I think, Claire, your research said a lot longer, didn't it?
Yeah, don't rely on my memory for anything.
Pauline, your finger up.
From our research over 1,800 sessions at the moment, we're finding probably for impacted family members, it takes around 10 to 12 years to reach out for support. But what we're also finding is it depends a lot on the alcohol or other drug that's used. So with younger people with cannabis, there's a lot of people reaching out a lot, parents are reaching out a lot sooner. For partners with alcohol use disorder, they're actually taking a lot longer to reach out. So, but on average, we're finding it's probably around 10 to 12 years, and that's from quite a lot of research that we have done.
And they're people who have reached out, right, Pauline, because they're
yes.
in your services.
That's right. That's right. But we also talk to many other people that aren't in that research that we do. And it's really varied. And it's a lot of it's by word of mouth. It's like when somebody's done a program and then they'll recommend that to other people, but it's really difficult to reach everybody because everybody's at a different stage. Especially in New Zealand and especially culturally, that's a huge factor, and it works differently culturally in New Zealand. It's much more about people who are already tied into services, whether it's Asian or whatever it is. So it's very different in New Zealand. Yeah.
Yeah, I think from the research that I've done, very much what April was saying about the lack of awareness of what's out there seems to be a big barrier. I know a lot of the family members that I interviewed who had been with family drug support in Australia for whether it was months or a few years even, they only became aware of family drug support when they were Googling treatment or support services for the person who was using drugs. And they just happened to pop up on Google and they were like, oh, what's this? And kind of fell into it that way. Whereas if they hadn't stumbled across it, they might not have, it might have been another few years before they'd actually gotten the support. So yeah, I agree. I think just whatever the mechanism is to increase the awareness, I think that's definitely should be a priority. Yeah.
Yeah.
And I
It's
think that's
too. I think the other thing, and this is what I'm about to say, is about the 40 years that we've been trying to educate GPs around drug and alcohol use and doing brief interventions and using audits and using this and using that. And the sort of takeaway I have from that is that we do these blitzes and then there's turnover or changes or services disappear or whatever. And I think GPs get hit with a lot as well. That then the information's lost. Then you go back in and you do it again. And we've also done this in drug and alcohol in hospitals as well, and with nursing staff, where you get it in drug, and this is just to target the person with the focal person, as Pauline would call them, not necessarily the family, so it's hard work just even doing that. I think, and then we know that families don't necessarily identify themselves, but they probably do go and talk. But I do believe they talk to a lot of generalist counsellors, but they may not go for counselling for the drug and alcohol issue with the family member, which is just, they do go for their own mental health. So not meaning to sound put a dampener on that, but just that if something's going to happen in that space, it needs to be continuous, really. Yeah. As soon as, anyway, yeah. So I don't know quite how we do that, but I do wonder if it could be internet stuff, Paige, based on what you just said. because so many people search through the internet these days, and then you've also got the word of mouth is the other way, Pauline.
Mm.
It seems to be very powerful. Anyway, that's anecdotal. Adding that in. Anyone else want to say anything else? Anything else? I'm conscious of the time.